Things.
Good morning,
Hello.
Dr. Suman Bhandari, Dr. Haigrob Rao, and friends. Welcome to this beautiful conference venue and this very scientifically advanced meeting. So I've been asked to speak on antiplatelet agents in PCI. I think all of us know that aspirin and heparin were some of the first agents to be discovered, and we know that long back they were discovered and they have been used in interventional cardiology and other areas of cardiology as well. But this is how other agents also came up. Then came 2B3 inhibitors, and so many other drugs, Clopidogrel, bivalirudine, and so on and so forth. Finally Fondaparinux coming. So what has happened is that with these agents, the ischemic risk has decreased markedly now. So they are more and more effective, and because of their efficacy, the ischemic risk has decreased. Unfortunately, what has not happened is that the safety has not matched as much, and it remains similar kind of safety profile as it was long time ago. So now coming to the history of use of antiplatelets, and we know that use of aspirin in coronary artery disease is well known, but what we have to understand is there are situations in coronary artery disease when there is enhanced antiplatelet aggregation or enhanced platelet aggregation, and these are the situations where we need a dual antiplatelet therapy. So for example, in acute coronary syndrome, this thing happens that you have an enhanced platelet aggregation, and therefore you need dual antiplatelets. And the dual antiplatelets that have been widely popular have been thienopyridine derivatives like ticlopidine or clopidogrel. Now acute MI is another situation where not only there is exaggerated platelet aggregation, but there is also thrombus formation. So besides dual antiplatelet therapy, this is an area where we require anti-thrombotics also, like heparin. In PCI again, there is another situation where there is a plaque modification, and not only, there is lot of platelet aggregability, but also hypercoagulability. And therefore, in this situation also, we need potent antiplatelet agents along with anticoagulant agents as well, like heparin or, some other agents. But when stenting started actually, then it was realized that this platelet aggregation persists even after the procedure. So while it was well realized that during the PCI procedure the platelet aggregability had increased, and therefore dual antiplatelet therapy was required at that point of time, but with the advent of stenting it was realized that this platelet aggregation persists for a longer duration, and therefore if this special problem such as subacute stent thrombosis came up because of this enhanced activity, and it was realized that maybe you require dual antiplatelet therapy for a little longer period of time, at least 6 months maybe. With drug-eluting stent then came another problem, and that was late stent thrombosis, when it was realized that this enhanced aggregation of platelets was persistent not only till 6 months but even beyond, and maybe up to a year, 2 years, 3 years. And the reason was that there was a failure of endothelization of the stented part because of drugs that were given as a part of drug-eluting stent, and because of that this enhanced platelet aggregatability persisted, and then therefore you required a longer antiplatelet therapy, maybe year or more. But so the growth that has happened in interventional cardiology now is essentially focused on having better stents which don't have this enhanced platelet aggregability, so that you have to give antiplatelet agents for a shorter duration of time, at the same time having more potent antiplatelet agents so that they take care of this enhanced aggregability. So coming to antiplatelets, what is the best antiplatelet agent? What we need to know is what is the best antiplatelet agent, what to use and when to use and how long to give. I think those are the questions like we ask for any new drug or any drug for that matter, what, when, how, etc. Of course, most of us know that this is a platelet receptor, and we can see that there are multiple targets on the platelets. So which is a something, not very good, because you may have to target so many sites to get a good antiplatelet activity, but also good in certain ways that there could be many agents that could be used, and they could be used selectively in one situation or the other. But whatever said and done, there is one common final pathway, that is 2B3A, and therefore there are certain drugs which are effective on 2B3A inhibitors, and therefore they are more useful in that area, and they act on the final common pathway. Now coming to something classical, Clopidogrel we know is an effective antiplatelet agent with a good balance between safety and efficacy. It is drug of choice in chronic stable angina patients going for PCI. It is, however, ineffective in those patients where there is a clopidogrel resistance, and we know that there is something called clopidogrel resistance, and in those situations it may not be very effective, and they require, another disadvantage with this drug is that they require long duration of loading, at least 6 hours to act effectively. So these are some of the limitations, and we know that the reason for the clopidogrel resistance is that there are 2 steps when clopidogrel itself being a prodrug, and there are 2 steps before it finally gets converted into the effective metabolite, which is the anti-aggregating agent. And because of these 2 steps, anywhere if there is a block, then there is a clopidogrel resistance. Now because of this prolonged half-life, therefore, another problem is that if you load patients with clopidogrel for PCI and ultimately decide not to do PCI, you will have to wait for 5 days for the patient to be safely wheeled in for CABG surgery. So I think that is one important limitation of clopidogrel therapy as well. So there are, but certainly where, those situations where you require a good antiplatelet activity, even a quicker onset of action, but prasugrel ticagrelor could not be used for some reasons, it can still be used in those situations. And as you can see, across the spectrum of coronary artery disease, whether it is acute MI, whether it's unstable angina, whether it is PCI, long-term secondary treatment or primary prevention, whatever situation we take, clopidogrel is one solid antiplatelet agent which has got effectivity approaching up to 25%. So, it has been used in many situations, and lot of data in all these applications. Now coming to, what do we mean by platelet aggregation inhibition efficacy? And if we look at the efficacy, we see that aspirin has an efficacy of about 30%, so that means 70% cases it is not effective. Clopidogrel is effective in 40%. Unfractionated heparin as an antiplatelet agent is effective in 30%. The 2B3A antagonists have got a high efficacy approaching 80%. But if you use a dual antiplatelet agent, then this efficacy increases to 60%. And that is the reason why, the dual antiplatelet agents are used, that, efficacy of antiplatelet aggregation is increased. Now coming to prasugrel, this is the second drug that we will discuss. This has got the highest efficacy, but also the highest risk of bleeding. But it can be more useful in situations when you require more anti-thrombotic efficacy. For example, stent thrombosis, clopidogrel resistance, for example, leading to stent thrombosis, where you require, something better than clopidogrel. In acute MI situations and in diabetics with acute coronary syndrome, there you require more antiplatelet efficacy, and therefore you use a better agent which is more efficacious, albeit at a slightly higher risk of bleeding. But the problem with this drug is that it's got a long duration of action, and therefore, it requires about 7 days of discontinuation before surgery. So this is the real limitation of prasugrel, especially in acute MI situations, primary PCI, where you're not sure whether you are going to take patient for primary PCI or, you can actually do primary PCI, you might have to send for surgery because of left main triple vessel disease or something, So looking at this drug, we can see that again the efficacy is good, about 19% improvement compared to clopidogrel in terms of efficacy. This is the classic Triton TIMI 38 trial. But at the same time, although the efficacy is more, the bleeding risk is also 32% higher. So this increased efficacy is at the cost of increased bleeding risk, although the percentage of both of them are different. But looking at this special subset, that is a patient who has already got stent thrombosis or patients who are predisposed to stent thrombosis, we can see that prasugrel is much more effective compared to clopidogrel in preventing stent thrombosis. So in the balance of things, we can see that there are lower rates of stent thrombosis for prasugrel, there are lower endpoints, efficacy endpoints, but higher risk of bleeding. So the current place of prasugrel in acute coronary syndrome is that in those patients requiring primary coronary percutaneous coronary interventions, and those patients who have already developed stent thrombosis while taking clopidogrel therapy, or in demonstrated cases of clopidogrel resistance, possibly you can think of a prasugrel therapy. Of course, the contraindications are well known. All those contraindications which can increase the risk of bleeding, for example, age more than 75 years, weight less than 60 kg, and both of them being a relative contraindications, but the real contraindication is somebody has a stroke or even TIA. Now coming to the latest agent that we have is ticagrelor, which seems to be the most balanced of all anti-thrombotics with very good efficacy but only slightly increased risk of bleeding. Therefore, it can be used not only in acute coronary syndromes but in chronic stable angina as well, and can be used both in invasive as well as conservative strategy. Whereas prasugrel, if you remember, is used only in invasive strategy. But more importantly and more interesting is that it is the only agent other than aspirin which has shown a mortality benefit as an anti-platelet agent. And the only contraindication being severe bradycardia or rest dyspnea. So these are the only contraindications, or maybe even relative contraindications. Good thing is that it has got a rapid onset of action, nearly that of prasugrel, but not only that, it has also got a short duration of action. So that, it requires only 3 days before discontinuation for surgery. And I think this has very important implications. So people going for a primary PCI, you are more safer off with ticagrelor, because you know that once you discontinue ticagrelor, the action will rapidly wear off and the patient can be taken for surgery. So irrespective of the coronary anatomy, ticagrelor can be given, unlike prasugrel at least, where you need to know the coronary anatomy before giving it, because if you give prasugrel, then for 7 days patient cannot have CABG. Second important thing is that, as I said, it can be preloaded if you're knowing the coronary anatomy. That is a good advantage. Another important fact and of practical importance is that even if person is on clopidogrel or some other antiplatelet agent, on the top of that, if you want to increase the efficacy, you can still add ticagrelor for taking up for primary PCI with minimal increase in risk of bleeding. So despite being on clopidogrel therapy, it can still be loaded with ticagrelor. I think that is very, very important, especially in context of primary PCI. But the only issue is that the non-compliance can be very serious, and because of short half-life, if the patient misses clopidogrel for a couple of days, it's okay. But if patient misses ticagrelor for more than 1 day, it can be really dangerous. So I think with that in mind, and I'm sure all of us know about these Plato 1 results, which we know that there were 14 fewer deaths, 11 fewer myocardial infarctions, less cases of stent thrombosis, and but no increase in bleeding broadly. Now coming to the final agents, we know a little bit about them. GP2B3 inhibitors, they are good, but as we know that they can still reach up to only 70-80% of efficacy, so they are still not enough. Maybe you have to combine them with other antiplatelet agents also. But wherever you require a very good antiplatelet action, I think these are just mandatory, although their use has been declining because of more and more potent antiplatelet agents like ticagrelor or prasugrel being available. So their use has declined markedly, and now is less than 10% of PCIs done. So how to choose antiplatelet agents? And you can see that both prasugrel and clopidogrel have niche areas. Prasugrel is to be used in patients with ST elevated MI mainly, but you could also use in other situations like stent thrombosis or diabetics with acute coronary syndrome. On the other hand, clopidogrels are most safer and effective in chronic stable angina. But it is ticagrelor which across the board you can give in whatever indication and with least kind of limitations. So finally, to summarize, we can say that prasugrel should be used when immediate PCI is required, where you have short duration of action required, for example primary PCI or ACS with high risk ACS, where subacute stent thrombosis has already happened despite clopidogrel therapy. On the other hand, ticagrelor is useful. Basically, you require a good balance between safety and efficacy, where you require more efficacy, but at the same time you cannot afford to have more bleeding. So I think these are the situations. There are certain limitations to all the drugs, as we know. Thank you for your kind attention.
In your slide where you showed the platelet inhibition percentage, what about prasugrel and ticagrelol? Those were not in the slide. You had...
Yeah, they were the classical sort of things. The prasugrel and ticagrelol are by themselves around 60% efficacy.
Yeah, 60, and ticagrelol maybe...
Ticagrelol is slightly less than prasugrel. Prasugrel is more than ticagrelol, but safety-wise, ticagrelol is much better than prasugrel.
And also the 3-day with ticagrelol, the company still says 5 to 7 days.
Yeah, the guidelines are 5 to 7 days, but practically, after 3 days it can be
because
taken.
3 half-lives or so.
Right.
Fine.
Exactly right. So, so switch has been, discussed, especially with prasugrel. It is well known. For example, it is known that once you load with prasugrel, this high efficacy is there at the time of loading and persists for 1 month. But after 1 month, it does not matter whether the prasugrel is there or not. So people have advocated that after 1 month, you could even switch over to clopidogrel, whereas most guidelines say that you should continue for about a year or so. Or depending on till the dual antiplatelet therapy is continued, now it's 6 months. So it should be continued for 6 months, but practically people have done some, and there are some small studies available also where you can switch after 1 month of therapy. The same with ticagrelol is not available that much, that robust data is not available, but still I think intuitively one can think that if you want to switch over, then continue for 1 month with ticagrelol and then maybe switch over to clopidogrel if you want.
No, my question is, if you're switching from ticagrelol to clopidogrel for some reason, cost for example, do you think we should be overlapping the drug for at least a day, or should we reload with clopidogrel because clopidogrel is slow in acting? It may take about 6 to 8 hours, 12 hours for it to act. And
right.
Yeah. That's my question.
Yeah, so it should be overlapped for a couple of days because it takes at least 6 hours for its effect to start. So maybe a couple of days it should be overlapped.
Do you think we should reload with clopidogrel, or that's not necessary?
I mean, I have not seen any study where they have reloaded, so I don't know.
So if you look at prasugrel, it takes 2 days for the IRA to come down to even clopidogrel level. So stopping prasugrel doesn't switch it off. So you are safe with going to clopidogrel. On prasugrel, you can stop prasugrel and continue just clopidogrel. So I won't worry about that.
Yeah. Ticagrelol?
Same.
The ticagrelol has got a short action.
Yeah,
it still takes 5 to 7 days according to, you have 3 half-lives. So you miss 1 pill, it doesn't make... If you look at the pharmacodynamics, you look at the platelet inhibition curves, it still takes 48, 72 hours to come to even clopidogrel 40% IRA.
If you miss two doses of ticagrelor, then you are equal to clopidogrel.
Yeah.
If you miss 1 more, then you are much worse off. Yeah. So 2 you can miss actually.
Yeah. So it's quite safe enough, and that's a period where the vulnerability of the lesion and plaque to thrombosis is much less. You are overlapping over a longer time. And then you'll also, the next talk will make you also aware that now the stents you can even close dual antiplatelets up to 1 month even, or 3 months or 6 months. So that's another area.